Students, today we are going to discuss the imaging of intestinal obstruction and the treatment of intestinal obstruction. Imaging, you see, whenever a patient presents to you with intestinal obstruction, we usually get X-rays, isn't it? Erect X-ray abdomen and supine X-ray abdomen. Another investigation we do is CT scan. CT scan is very useful investigation to tell you the site of obstruction, cause of obstruction. In X-ray, supine films will tell you the dilatation of the bowel loops, the thickness of the bowel wall, okay, and erect X-ray will show fluid and gas levels, okay. Fluid will be seen first, then later on air will occur, and in erect X-ray you will see a multiple fluid and gas levels are there, okay. Have a look here. In jejunum, how do you know that this is jejunum or ileum or large bowel? In jejunum you have valvuli conniventis. Valvuli conniventis means the valve-like things are there. The shadow will be there which traverses the whole lumen of the intestine. Okay, that is valvuli conniventis. That is typical of jejunum. Jejunum. Whereas in ileum you will not get that valvuli conniventis are not that prominent. It's a sort of a featureless, also called featureless or characterless. In large intestine, the lumen will be broad, as in the volvulus. You see, in the sigmoid volvulus, which is the commonest type, you will get a coffee bean appearance or a bent tube appearance. Huge dilatation of the colon will be there and will look like a tube of the tire is bent. Whereas in cecal volvulus, the cecum will be pulled up, okay, and small bowel will be dilated. So further investigation we do is CT scan to confirm, and obviously we'll do all the blood tests, CBC, and check the electrolytes, especially sodium, potassium and all. Okay, because there is vomiting, patient has got fluid and electrolyte disbalance. Okay, so in treatment of intestinal obstruction, the broad headlines will be: first, if intestinal obstruction is there, you admit that patient. Okay, put him on nil orally, don't allow him anything to be eaten by mouth. Then we put IV fluid on, ringer lactate. Usually we start IV that patient on IV fluids. We put a Riles tube in sometimes to suck the fluid out. Riles tube. So you have IV fluid, Riles tube to suck the fluid out, and also we give antibiotic in case patient goes in gangrene and perforation. And if patient is in pain, you give painkillers. Okay. Usually in 48 to 72 hours, most of these obstructions can resolve. Some of these obstructions can resolve. But if it is not resolving, or if distension is increasing, patient is becoming toxic, count is increasing, total count is rising, patient has got neutrophilia, fever, severe pain, peritonitis, then it means patient has to have laparotomy done. Some sort of surgery have to be done. So we do a laparotomy, usually from midline incision, and have a look. Usually what happens with the site of obstruction, the proximal bowel will be dilated. Proximal bowel will dilate, there is a point of obstruction, and distal bowel will be collapsed. So you know that there may be band there, so you have to release the band. There could be intussusception, so you have to reduce the intussusception by pressing on the distal segment so that it comes out. If there is volvulus, we derotate it, as I told in previous sections, derotate it. If it is gangrenous, we resect it and do an anastomosis. So if there is a tumor, you have to resect it. So treatment depends upon basically what is causing the obstruction. Okay, so broadly, you put the patient nil orally, IV fluid, antibiotic, painkiller, and then see if patient needs operation, especially if somebody has got a strangulated hernia, and if patient is getting toxic, severe pain, if there is no previous surgery. Usually if patient had previous surgery, it means it is more likely to have adhesion obstruction. Okay. So if there is no previous surgery or more worried, it means there is some other causes there. Okay. So basically after opening up, we treat the cause of the obstruction. What is causing? If it is band, release it. If it is interception, reduce it. If there is a tumor, we have to resect it. If there is volvulus, derotate it. And in sigmoid volvulus, mostly we resect and do end-to-end anastomosis, because otherwise it will recur again. Okay. So this is about the treatment of intestinal obstruction. There is one condition called pseudo-obstruction, and there is also one condition, paralytic ileus, in adynamic obstruction. In adynamic obstruction, there is no mechanical obstruction, but functionally peristaltic movements have ceased. And why it has ceased? Usually there is some predisposing conditions like uremia. In uremia, or post-operatively after surgery, patient goes into paralytic ileus for 24 to 72 hours. And there could be retroperitoneal bleeding, hemorrhage, pancreatitis, uh, trauma. These all can lead to paralytic ileus, and but then in these cases treatment is conservative and treat the cause, and then this obstruction will be relieved. Okay. And there is one condition called pseudo-obstruction. Pseudo-obstruction, also there is no mechanical obstruction, but patient is obstructed. It can be pseudo-obstruction of the small intestine, pseudo-obstruction of the large intestine. And usually seen in those conditions also uremia, retroperitoneal hemorrhage, bleeding, pancreatitis, patients on anticholinergic drug, antipsychotic medications, they all can lead to pseudo-obstruction. Pseudo-obstruction of the large intestine is also called Ogilvie's syndrome and seen in elderly population. Okay. So here usually what we do is colonoscopy. If bowel preparation is done in colonoscopy, that will be diagnostic as well as therapeutic in these cases. And sometimes neostigmine is used, 1 milligram IV to stimulate the peristalsis for pseudo-obstruction. Okay. See, and in intestinal obstruction, when you have opened, the another thing which I have missed is sometimes there could be confusion whether this part of the bowel is viable or non-viable, or gangrenous or not gangrenous. In that case, what you do, we ask the anesthetist to oxygenate, increase the oxygen flow to the patient, and wait for some time to see if the normal color returns or not. You see, we palpate the mesentery and feel for the mesenteric vessels. In viable colon, there will be mesenteric pulsation, and the color will become from dull to a normal sheen will return, and also peristaltic wave will return, and it will become reddish or normal hue. Then you know that this bowel is viable. Okay, so this finishes our intestinal obstruction.